Good morning. So today topic is on metabolic bone disorders. So all orthopedic surgeons have to deal with bones always. It may be healthy or diseased, and that's why we need to know about bone metabolism in detail. So bone is very important as it protects the vital organs of the body and also it gives support to the muscles and tendons. Bone also can become weak in certain conditions and may lead to problems that we have to study. There is always a continuous activity in bone during all stages of life. There is a continuous bone resorption and bone formation as well as remodeling of the bone going all throughout our life. So that means bone is not only for protection and support but also its contents plays an important role in blood homeostasis. So many factors are involved in this bone metabolism that we will see in the subsequent slides. So bone metabolism is controlled by many factors like calcium, phosphorus, parathyroid gland, glucocorticoid hormones, intestinal absorptions, renal excretion, diet, vitamin D, and sun exposure. So bone is basically contains is made up of two things. One is the bone matrix and the cells of the bone. Okay, in the bone matrix there is 40% is made up of organic things and 60% of bone matrix contains the mineral things. Okay, so the 40% organic is made up of collagen type 1 whereas 60% of the minerals is made up of by calcium hydroxyapatite, phosphorus and other traces of elements. The cells in the bone includes osteoblast. So let's see in short about the vitamin D metabolism. So vitamin D is produced in our body either through our sun exposure or through the food content. Okay. So for example, when there is a sun exposure, then our D-hydrocholesterol in our skin gets activated and it's further activated in the liver into 25-hydroxycholesterol. This thing goes into liver and further activation of vitamin D happens. Here it converts into fully activated form of 120-dihydroxycholesterol. So this is the active form of vitamin D and this function of vitamin D is to make absorption of calcium from the intestine. So this helps in absorption of calcium from the intestine and also it helps in calcium deposition in the bone. Okay. So this is a basic function of vitamin D. Okay. So coming to parathyroid hormone. So parathyroid hormone is produced from the parathyroid gland in the that is situated in the thyroid gland actually. So this parathyroid production is stimulated when there is a serum calcium level is low. So when the parathyroid hormone is secreted, its function is to increase the calcium levels in the blood by increasing its release from the bone and also by increasing absorption of the calcium from the intestine. And also it increases the reabsorption of calcium from the kidney also. So through that means it increases the serum calcium level. So coming to calcitonin hormone, which is its action is directly opposite to parathyroid hormone. It is secreted by C cells of thyroid gland and its secretion is also regulated by the serum calcium level. When serum calcium level is high, then calcitonin hormone is stimulated to produce. When it is produced, it acts to inhibit the bone resorption of calcium and also it increases the calcium excretion in the kidney, thus by reducing the calcium level in the blood. So coming to osteoporosis or bone strength. Bone strength is affected by the mechanical stress, that is the kind of exercises we do, the kind of weight bearing activities that we do. And bone strength gets reduced with menopause and the advancing age. So the reduced density of bone in X-rays is called as osteopenia. Advanced osteopenia is called as osteoporosis. Bone density is diagnosed by using a test called DEXA scan. Okay, but one thing we should know that increased bone density doesn't mean strong bone. Sometimes a pathological condition like brittle bone disease where the bone is dense but actually it's very fragile. So we should not collaborate like high dense means strong bone. Sometimes pathological bones also high density but it still be weak. Okay. So these are the conditions that we are going to discuss in bone metabolism. One is the rickets, osteomalacia and osteoporosis. So what is rickets and osteomalacia? Both are different expressions of the same disease, that is inadequate mineralization. So rickets affects children's, whereas osteomalacia affects bones of adult people. So what are the causes for rickets and osteomalacia? It may be a calcium deficiency or a phosphate deficiency or defect in vitamin D metabolism. So defect in vitamin D metabolism may be due to nutritional causes or underexposure to sunlight or intestinal malabsorption or any problem in the liver and kidney disease will also affect vitamin D metabolism. So coming to rickets, so the symptoms of rickets in children are child is very restless and babies cry without any obvious reason. There will be failure to thrive in case of children. Muscle weakness will be present. In case of very low level of calcium, there will be convulsions can occur, and there will be joint thickening in the wrist and knees, and deformities of the limbs can occur as child starts to walk Genovarum or Genovelcome. And chest we have deformities like pigeon chest deformity, ricket rosary like deformity can be present. In this clinical picture we can see, so because of rickets we can have that impaired growth of hairs and bossing of frontal bones, and dental defects will be present, and pigeon like deformity will be present in the chest, and the thickening of the costochondral junction will be present, that is noted as ricket rosary syndrome, and there will be kyphosis of the thoracic spine will be present, and pot belly will be very enlarged, and there will be deformities in the limbs like a coxavera in the hip, and genovarum or genovalcum in the knees will be present. Thickening of the distal end of bones will be present, leading to widened wrist and widened ankle and knee joint will be present. And in the X-ray you can see there will be widening of the physis will be present, and the cupping of the metaphyseal region, there is flaring of the metaphysis will be present, and there will be deformities of the bone, that is called O deformity will be present in the lower limbs. Coming to osteomalacia, it's bone weakness in adults. Okay, there is a defective demineralization. So its symptoms are like a patient usually present with the back will be proximal muscle weakness will be present in the shoulders and hip, and vertebral changes like biconcave vertebra and collapse of the vertebra and kyphosis of the spine also will be present, and there will be loose zone will be present in the scapula and the pelvic and even proximal femur also. So in this X-ray you can see there is a radiolucency in the proximal femur which is called as a loose zone. This is a sign of uh, osteomalacia in adults. Similarly, in the spine, there will be collapse of the vertebra will be present, leading to compression fractures. So treatment for both rickets and osteomalacia is adequate vitamin D replacement and good sun exposure. And if there is any residual deformity, we have to correct the deformity either by splints or by surgical method. Coming to osteoporosis, it's actually here there is no problem with the mineralization, but actual bone mass is decreased. This is the difference between rickets and osteomalacia and osteoporosis. Osteoporosis, mineralization is okay, but the bone mass is decreased here. So in this picture, we can see this is a normal bone. See how thick the bone architecture is there. Whereas in the osteoporosis, you can see a lot of holes in the bone. So the architecture is very much changed. There is a weakness in the bone because of very loose architecture. So types of osteoporosis is either primary or secondary osteoporosis. Primary osteoporosis can be further subdivided into postmenopausal or senile type. So the postmenopausal osteoporosis occurs due to rapid decline in estrogen level after menopause, and it results in increased osteoclastic activity. Normally the bone loss will occur at the rate of 0.3% per year, but after menopause the loss of bone is around 3% per year. It's very rapid. Coming to senile osteoporosis, it occurs even in males at the age of 7 to 8 decades in life, and there will be steady loss of bone at the rate of 0.5% per year. It's a part of physiological manifestation of aging, and risk factors in senile osteoporosis is male menopause, dietary because of less calcium and vitamin D levels, and muscle weakness and reduced activity. Coming to secondary osteoporosis, may be induced by certain drugs and conditions like steroids intake, alcohol and smoking, phenytoin and heparin drug use may induce secondary osteoporosis, and metabolic conditions like hyperparathyroidism, hypothyroidism, Cushing syndrome, hormonal disorders, malabsorption, malnutrition may lead to secondary osteoporosis, and chronic diseases like rheumatoid arthritis, renal failure, and tuberculosis may also lead to secondary osteoporosis, and malignant conditions like multiple myeloma, leukemia also can lead to secondary osteoporosis. And disease osteoporosis is a condition where, because of post-traumatic conditions or because of immobility of the patient, the limbs are not used for a certain period of time, then bone weakness may occur in that limbs. So this is called the disease osteoporosis. This occurs locally in the particular limb. Okay, it may be generalized in a bedridden patient also. So awareness of this is very important to prevent this condition. Coming to osteoporosis, this is a very silent disease, unlike osteomalacia or rickets, where it is more symptomatic. Whereas osteoporosis is a silent disease. The main problem with osteoporosis is it may lead to complications like fractures. So osteoporosis does not usually cause pain, or unless it causes any fracture. So there will be gradual increase in dorsal kyphosis in case of osteoporosis, lead to shortening of the patient and lead to loss of height. And osteoporosis is not related to osteoarthritis. Both are different conditions, but both may coexist in a same patient. So the main complication of osteoporosis is the compression fractures. It may either occur in the spine, especially at the junction of the thoracolumbar junction, or it may commonly occur in wrist, leading to Colles fracture, or it may occur in hip also, leading to fracture neck of femur. Okay. So the difference between osteomalacia and osteoporosis is, in osteomalacia can occur at any age, whereas osteoporosis usually occurs in old age, like after menopause or after a 16th on the decade of life. Here in osteomalacia, patient will be ill, whereas in osteoporosis, the patient will not be that much ill. There will be generalized body ache will be present in osteomalacia, whereas in osteoporosis it will be asymptomatic unless some fracture occurs in osteoporosis. Muscle weakness will be present in osteomalacia. There is no muscle weakness in osteoporosis. Loose zones will be present in extra in osteomalacia. There is no loose zone in osteoporosis. And in biochemistry, alkaline phosphatase level will be increased and phosphatase will decrease in osteomalacia, whereas in osteoporosis, biochemistry will be normal. So prevention of osteoporosis should start from childhood. You have to get good healthy diet, adequate sunshine, regular exercises, avoiding of smoking and alcohol, and avoid using of steroids are helpful in avoiding the osteoporosis. How to treat osteoporosis? So dietary intake of a lot of calcium and vitamin D will be helpful to reduce osteoporosis, and after there are certain drugs like bisphosphonates are there, like alendronate, pamitonate, and zoledronate, which will be helpful in reducing the osteoclastic activity and improve the osteoporosis. And there are other drugs which improve the osteoblastic activities like proteolysis, and newer drugs like denosumab are available, which are helpful in drastically improving the osteoporosis level. And even another new injection like teriparatide is also available, which improve the osteoporosis level. So once when there is a fracture in the spine, how to treat these conditions? So we can treat to conservative method. One another technique is surgical method. So surgically we can treat this osteoporotic compression fractures by using two techniques. One is called vertebroplasty, where we inject cement into the compressed bone. Another technique is the kyphoplasty, where we introduce a balloon into the affected spine, and into the balloon we inject the cement, so that we distract the bone and correct the deformity in the spine. Okay. So coming to hyperparathyroidism, so it may be of three types: primary, secondary, or tertiary. So when there is increased secretion of hyperparathyroidism, that leads to increased bone resorption, and subperiosteal erosions will be present, and osteoitis will be present in the bone. So it leads to significant hypercalcemia. Okay. So in very severe cases, it leads to bone tumor formation also. So in hyperperson, there will be generalized decrease in bone density will be there, and you can see bone tumors and chondrocalcinosis in the bones. So this is an X-ray which you can see bone tumors. There is similarly in the wrist and fingers, you can see superior bone erosions seen in the phalangeal bones. So these are signs of hyperparathyroidism. So the treatment is you have to treat the primary cause. If it's a primary hyperparathyroidism due to adenoma of the hyperparathyroid gland, then you have to excite the gland. Secondary hyperparathyroidism occurs because of some decreased low calcium level in the blood. So you have to improve the calcium level so that you can correct the secondary hyperparathyroidism. Tertiary cause is due to continuous stimulants of low calcium level in the blood. So you have to, it leads to autonomous nodule formation that leads to tertiary hyperparathyroidism. So you have to exercise that autonomous nodule. Okay, but one thing we should be very careful is once we remove the hyperparathyroid gland, there will lead to sudden hypocalcemia due to hungry bone syndrome. So it's very important to avoid hungry bone syndrome when you do surgery for secondary for hyperparathyroidism. So you have to continuously monitor the patient, and if the patient is going for hypocalcemia, then you have to supplement the patient with IV calcium and vitamin D. So that's all, and thank you.